For many of you, that first visit to the neurologist might have been the most scariest thing you've ever had to do in your life. It's very different to visiting a respiratory physician, your GP, or a cardiologist. We're now talking about your brain. What the neurologist is thinking about is completely different. They're thinking about, does this patient have MS, or could they have something else? How could I make the diagnosis, and where do I think they're going to be in the next 5, 10, 15 years? So there is a disconnect already from the outset with the patient and the clinician. Now, knowing what the visit is about, in fact, is quite helpful for the patient. And whereas as clinicians, we get an information letter from the GP, so it's not so helpful. But by knowing each visit or what to expect for the future can in fact empower you in many different ways to kind of start directing your own care in a way for each of these visits. So I'm here to talk today about the neurology toolkit, what's in the neurologist armamentarium and what they're going to be talking to you about and what they're going to be examining. Now, I can't stress that the biggest thing for neurologists is their clinical skills. There's been new developments over time, and we've got fancy instruments now, but for neurology, it is all about finding out which part of the central nervous system is affected, how often, and how the disease has evolved. So as a clinician from the outset, it's all about the history and the examination. Your clinician needs to be very good at this because the other investigations which they request is there to confirm what they already know or suspect at the visit. They might not tell you because they're concerned about how you'll take the actual answers which you have to give and might wait until the next visit or subsequent visit to talk to you about it. Now, one of the problems with the first visit is that most on average wait 6 months to a year to see a neurologist. And the main provider or provider of information for you happens to be Dr. Google. And we can't get away from that. Unfortunately, all of the MS symptoms which you heard about this morning can fit any other disorder which can affect the central nervous system. But clinically, the neurologist is there to break it all down and say, this fits more consistent based on the age, based on the gender. This is more likely to be MS than it is to be Parkinson's disease or to be Alzheimer's disease or to be encephalitis, XYZ, you know. That's our job. But with the era of development of the CT scan and with MRI, we now have ability to say convincingly that this is what we're looking at. So you may not be able to get an MRI on the first visit. And for people living in the islands, I heard all about it yesterday, about scan appointments being given this morning, in fact, at 8 a.m. for somewhere in Glasgow. I mean, that's ridiculous, but this is the way things happen in the islands. And the other is lumbar puncture. So by taking a sample of your spinal fluid, you can tell whether there is, in fact, activation of the immune system in that spinal fluid space. So the two pieces of information which you get from the investigations is a picture of what's going on in the brain and what's happening at a biological level. The neurologist then puts the two together, fits it with your clinical presentation and gives you that answer. What we're most likely dealing with is multiple sclerosis. And that's the reason for the investigations. Now, also going through the mind of the physician seeing you is this patient sitting in front of me suitable for clinical trials? Now, clinical trials come with a huge paranoia about, I don't want to be participating in research, they might be poking and prodding me, but in our mind, it's about allowing patients access to new treatments or new concepts or new ways of measuring, monitoring, etc. They're fully funded, and therefore there's no issue with what can be obtained in terms of information about your disease. But most importantly, they give you that access to the drug which has been recently licensed, like ocrelizumab, which went into clinical trial, and then I think alemtuzumab, which went into clinical trial back in 2005. So you have access to early treatment. So that's also something we're thinking about. Now, the clinical trials are not easy to do, I'll say that. For patients, it's hard work. The morning starts off at a trek, and you're doing various assessments, scans, and even lumbar punctures. But it's useful to know what these tests are when you sign up for them. And then last but not least, the future of MS care, I think, is going to be self-monitoring. So you may not visit your neurologist unless for a relapse or to find out if you think you're progressing. Your apps will tell you if you've had a relapse. So if memory is an issue, like you said, the app will pick up that relapse way before you even realize and let your MS nurse know that this is what's happened. And I think that's the future of care in MS. So investigations, we start off with the MRI. The MRI shows you the white matter lesions, and as you can see, the lesions are evolving over time. This is a composite of many scans done over 15 years. Okay. It's kind of scary seeing these lesions pop up over time. But the important factor here is MRI is not useful not only at the diagnostic phase, but to monitor the disease. If you're accruing more than 1 or 2 lesions on a yearly scan, when you're on a disease-modifying treatment, you need to question the efficacy of it. So there's a concept called NEDA, which stands for No Evidence of Disease Activity. And to prevent long-term problems with disability and loss of brain volume, you need to be targeting this disease very early on and keeping a very tight control through MRI monitoring. We try and do MRI once every year in all of our patients to see where they are. And that makes clinical visits very interesting. My secretary gets a call after 1 month period just to find out what their MRI report is, and then there's a visit to discuss things. It's great if your disease is stable, not so great if it isn't, but it's there to change and swap treatments based on new lesions being accrued on the scan. So MRIs become invaluable in terms of monitoring the disease nowadays. Now, Stuart touched on brain volume loss. On the left, you have a person with a normal brain. On the right, you have someone with MS brain. I mean, this isn't early disease, by the way. This is more further into the disease. And that's what you're trying to prevent, really, because you can't see well on the MRI, but you're also losing cortical volume, which leads to the cognitive problems you'll face. And also by losing tracks, there's disconnection, which leads to others, cognitive fatigue as well as generalized fatigue as well. Now, the thing to realize about brain volume loss is that it occurs throughout the disease. So you can see it not only in primary progressive and secondary progressive phases, it's there when you present with your first incident symptom, or CIS, that's what we call it. And it's kind of constant throughout the disease phases. So the trick here is not to wait for the secondary progressive stage, is to treat early. So if we are able to get atrophy measures, which not many places have, and in fact it's all still in clinical research, we would be able to say at another level, not only stopping lesion formation, but is there loss of brain atrophy? Now, we know that there are a lot of highly active treatments available to us now which target brain atrophy loss. One of them is alemtuzumab, which within 4 years returns a rate of brain volume loss to the same level as an age-matched control. So if you can return the loss of brain volume back to whoever is next to you who doesn't have MS, then that's an amazing achievement as far as MS treatments are concerned. So that's another level in the no evidence of disease activity demonstration. So that's MRI. Now we come to the CSF, and you can see that you have your brain, which sits in a CSF compartment. So CSF stands for cerebrospinal fluid. And you have roughly 150 to 160 mils of CSF in your brain, as well as surrounding your spinal cord. This renews itself 4 times in a day, producing an approximate figure of 600 mils in a day. In a lumbar puncture, we take about, at most, 5 mils. I know the whole procedure takes 45 minutes. What we managed to take is 5 mils at most. You can safely take up to 10 mils, and the rate at which it comes out is a drop per second as it's dripping into our tubes. The lumbar puncture is there not only to show the presence of oligoclonal bands or antibody synthesis, it's also there to exclude various other things like viral infections. Also another mimic of MS called neurosarcoid. If you're an Afro-Caribbean person, it will be pertinent to exclude that out, or other conditions like vasculitis. These are all other mimics of MS. So there is utility for the lumbar puncture, aside from just MS. But then there is a huge phobia associated with LPs. You can't detract from that. And in some cases, it's about the unknown. So we did a couple of years back a small survey looking at what people's experience of lumbar punctures were. And you can't see this from the back, but I'll just read it out. So the top half is where it's very good to good, and then the bottom half is where it's terrible, okay? So majority, the purple bar thought it was satisfactory, their lumbar puncture experience. And the light blue bar at the bottom thought it was severe. Okay. Now, over the years, this has definitely changed, and people's experience of lumbar punctures have changed, and that's important to explain that to people. It's amazing how acceptable an LP becomes, particularly in women, when you tell them it's the same thing as an epidural, because many of us now have epidurals during pregnancy. And if you explain it in that fashion, it's like, oh, okay, it's just an epidural. And they've had that already. So it's worthwhile asking a person if they've had an epidural during pregnancy. But as with everything, technology evolves and the needles have changed. So what they had back then, which looks like a massive needle, is now much tinier. And what this is trying to demonstrate is the older needle type is at the bottom, which is the Quincke needle. So it cuts through the layer which surrounds where the spinal compartment is. Whereas the newer needle hardly makes a cut because it's parting the fibers. So it's slightly more blunter and therefore just parts the fibers. Now, one of the biggest complications of having lumbar punctures is a post-lumbar puncture headache. And in fact, for many who had it when we were using the Quincke needles, this was the problem. About 30% of patients have post-LP headaches. But with this new type of needle, the actual occurrence of that has been reduced by 50% to roughly 3 to 5% of people experiencing post-lumbar puncture headaches. Now, who's had a post-lumbar puncture headache in the room? Okay, quite a few of you. It's better to tell people about this at the first visit as well, if you're going to send someone off for a lumbar puncture, and how to manage it. What happens, I generally advise people not to do anything strenuous for the day, because running around doing your general activities leads to exacerbation of the existing problem, and therefore then worsening of the symptoms. If you tell people also how to manage it, which is bed rest, unfortunately. And over time, it will lessen and things will return back to normal. So, but Post-lumbar puncture headache, unlike all the other things which you think might happen during a lumbar puncture, is the side effect to be aware of. Okay. Now we move on to stuff which you might come across during clinical trials. So if we think about what's being measured in clinical trials, all the drug trials are trying to show is there a slowing down of disability with their XYZ drug? That's important to understand. And how many of the audience here in the room participate in a clinical trial at the moment? Any of you? One person. So you've heard of the EDSS and you've done it. How long do you think it takes to do?
Yeah, a couple of hours.
Yeah, I think waiting to see someone. Yeah, so it is a neurologist who does it regularly can do it in 10 minutes. Okay, there's a lot which you can skip through, but as you can see on the top left-hand corner, there's a two-side to the EDSS score, which are the functional systems which I have to fill in. But someone who does it regularly can do it within 10 minutes. Whether it's reliable is another question, but it can be done quite quickly. Now, you see the lady on the left doing one of the assessments. That's to see if you've got any cerebellar or balance problems. So this gives us an idea of monitoring your level of disability accrual or stability of your disability during the clinical trial. And it is the basic outcome which is in every single clinical trial. And you will come across it if you do have it done, if you do participate in trials. Now the next thing is another way of measuring it. So the EDSS is very heavily reliant on your walking. It's not good at telling us if there's anything else worsening. But what we're interested in also is looking at upper limb function. Is there any problems with that? Is there any problems with cognition? And actually measuring other aspects of MS which we would like to modify with the drug. And PEG tests are very good at showing you if there is any problem with the upper limb. So this is a cardboard PEG test. There's couples sitting on the table to your left, so you can take one per family if you'd like, and try out your 9-hole PEG test speeds. So what you have, and you might have done this at school in fact, you have a couple of pegs sitting in this circular compartment here, and you pick out each peg and you put it back in. So effectively they all start off like this. So if you imagine, let me take this out, and you have to time how quickly you can put all the pegs back in and then take them all back out. And that gives you the timing for how good you are in terms of speed as well as coordination. You measure it for the left hand and the right hand, and it's surprising how different the two hands could be. The dominant hand definitely does better unless it's affected most by your MS. And this is good at showing things wrong with your upper body, not just your lower body. Now, it's frustrating and there is a learning effect to it as well. So the number of times we're there on the floor looking for these little pegs if they get knocked out. But practice makes perfect. So, and I think the learning effect is not just the typical learning effect. You are, in fact, improving your upper limb function by doing it repeatedly. So there is something going on there aside from that. Now, in terms of next thing in clinical trials, moving away from the assessments, we're now going into the biology of the disease back into it again. So you may participate in trials with lumbar punctures in it. And one of the latest developments in CSF research has been what's called the neurofilament proteins. These, as you can see, if you've looked at the neuron and the axon, the filaments sit within the axon. They not only maintain the size of the axon, they also determine the function of the axon in terms of how fast things get from the cell body down to the bottom end. Now, during an MS attack, you get damage of the myelin sheath, but there's also damage to the axon, and these filament proteins get released into the CSF space. And there are various different types of filament proteins, from light chain through to heavy chain. And in fact, they can be measured either in lumbar puncture, but if you're in a clinical trial, it could just be a simple blood test. Now, what this tells you is about disability. If you've got loss of axon, you're more likely to accrue disability over time. And this allows us to see if the drug's effective. So this is a graph which demonstrates this from one of our clinical trials, where you've got the timed walk over 25 feet. And to your right is how many seconds it took for people to complete the test. Now, on average, the longest person to complete the test was 240 seconds. If you had normal or absent neurofilaments in your blood test, about 90% of the participants completed the test in under 30 seconds. That's the green dotted line. If you had raised neurofilaments in your blood test, you took just under 150 seconds to complete it. So that's where the biology of the axonal loss tells you how the disability is accruing. Okay? Now, those are clinical trials. If we look at what can you do over time in the future, this is all about self-monitoring. So there are now online calculators where you can monitor your own EDSS and let your MS nurse know about where you think your EDSS is currently standing. This gives you an idea of whether things need to be changed as far as your drugs are concerned. Also variables about which can either be in a watch or worn around your body, which gives you not only the pulse, heart rate, but also your walking distance. Whether you've stopped moving is very important, because that means you've had a bad relapse, and this can be picked up with wearables. This is going to be the future of MS disability monitoring, because it will tell us more accurately if there's been a relapse. We no longer will be reliant on people's wondering over the last 6 months, did I have a relapse? This printout will give you, oh, that's a relapse, that's a relapse. Damn, this medication is not working. Okay? So that's going to be the future of MS.